Good afternoon to everyone on the east coast of Australia, and still good morning to those watching in Western Australia. Welcome to the PCFA's latest webinar, and I know that this webinar is something that a lot of people have been looking forward to, and there is a lot of interest in our presentation and our speakers today. We have Dr. David Dangerfield, who's a urologist, and Professor Chris Coombs, who's a microsurgeon, who are our very special guests today. And also we do have Tony French, who is actually a patient, who will be giving us his view on things as well later in the presentation. So look, this is something that's new, and over the past, I guess, 6 years, I think David and Chris have been working on this very exciting new approach to the post-radical prostatectomy and the erectile dysfunction, using the nerve grafting technique. And I know that there's been a lot of interest in this because obviously one of the side effects of prostate cancer is often erectile dysfunction, and this is amazing new breakthrough and new research that's happening, and I'm looking forward to the presentation myself. So I'm very pleased to hand over now, I think, to Dr. David Dangerfield, who's going to take the presentation away now. So thank you.
Thanks very much, Jim, and thanks for inviting myself and Chris on today to present our work. And before I get started, actually, could I also thank all the support groups and also the nursing group through the PCFA that we've spoken to during this interesting year, and in particular Alan and Fiona White down here in Melbourne, who've shown a lot of support. I will start the presentation today and discuss more generally penile rehabilitation and link it into the physiology of what we're dealing with before I hand over to Professor Coombs, and that'll make it a bit easier to understand the procedure and how it works. And then I'll come back after that and discuss our up-to-date results and how we're assessing our patients before moving on to invite Tony French, one of our patients, to share his experience. So penile rehabilitation, I think we're all pretty familiar with this term. It's really coincided with the development and the greater understanding over about the last decade of how men recover from prostate cancer, and in particular radical prostatectomy. And that also ties in with that concept of survivorship that we all know well now. And because the way we set about treating prostate cancer and aiming to get the disease early on, most of the patients do very well and live long lives. So we're focusing in now more than ever on the quality of life they live with for such a long time. Traditionally, urologists, and I'm a urologist, we're very cancer centric. So we're very PSA centric in your recovery, and we look at your continence, and your penile rehabilitation or erectile dysfunction is always a bronze medalist, can I say. But over the last decade, with the evolution of the concept of penile rehabilitation and its impact on men, on their mental health, on rates of depression and anxiety, and on their relationships, there's been a greater understanding. And really now, certainly in my practice, of course, but a lot of practices now, penile rehabilitation is more of a mainstay. So strictly speaking, penile rehabilitation is maximising the physiological processes, particularly around the penile corporal bodies, the actual tissues, and keeping the tissues as healthy as possible, and more specifically the blood vessels as healthy as possible, while the patient recovers from their surgery. And what we're meaning by that is while the patient is recovering from the nerve insult. So more specifically, it's any process, any device, any treatment that maximizes blood flow to the corporal bodies which keeps all the cells as healthy as possible there, all the tissues as healthy as possible while you're waiting for the nerves to repair. So it's about keeping the tissues healthy and preventing scarring, because we know scarring can be permanent, and it doesn't matter what treatment you have. Once you've had scarring in the area, it's very difficult to recover any form of spontaneous erection. So just to go back a step there, why do men get erectile dysfunction from radical prostatectomy? Well, the overwhelming mechanism there is neurogenic. So it's damage to the nerves. It can be direct damage to the nerves, particularly in a non-nerve sparing radical prostatectomy where there's a larger tumour that requires a more comprehensive resection. There can also be a neuropraxia or bruising of the nerves, and that can be more commonly seen in a non-nerve sparing radical prostatectomy. And this is the overwhelming mechanism for why a large proportion of men have erectile dysfunction after their surgery. There's a smaller proportion of men that can have an arterial injury to their erections, and they're very difficult to treat. And later on in the recovery, you can have venous scarring, or you can have scarring in the corporal bodies that leads to a venous, and that's a different blood vessel that causes erectile dysfunction, and that usually comes a little later on. So just quickly, just to touch on the physiology here, and this is a busy slide, but all I'm trying to get across here is that these are the nerves coming in to the penile corporal bodies, and they're the nerves that are damaged during a radical prostatectomy, and they bring in particular chemicals. Acetylcholine is the most important one, and all the purposes of these chemicals is to relax the blood vessels. The blood vessels there have small muscles within them, and an erection is perpetrated by relaxation in those muscles. So whatever stimulus is required for arousal, the nerves then secrete acetylcholine. It relaxes all of these muscles, and then there's an inflow of blood in here into the corporal bodies, and you can see the area just fills up with blood, and these are arteries that bring in the blood, dilate, fill up with blood, and at the same time as they're doing that, they're blocking off the veins. These little blue vessels here are the veins that are blocked off, so there's no blood can get out, and all the blood vessels dilate and bring all the blood in. So the key point here is that the nerves secrete acetylcholine, and this is what brings the blood into the area and causes an erection, and we'll come back to that a little later on. Penile rehabilitation to date has three mainstays. Tablets, the phosphodiesterase inhibitors, Viagra is the most famous one, intracorporal injections, and vacuum devices, and these are all commonly used now. The phosphodiesterases, drugs like Viagra, propagate the blood vessel dilatation and propagate more blood coming in. So they're quite simple in their mechanism. However, for the blood vessels to be dilating and bringing the blood in to bring on an erection, you need that nervous impulse. You need the acetylcholine coming out of the nerves to lead to the blood coming in a more major way. So theoretically, if your nerves aren't working, you're never going to respond to these medications very well. However, they are everywhere now, and they're very easy to use, and I think the majority of them are off patent now, so they're very cheap, and the majority of guys use these drugs for a long period of time after their radical prostatectomy. A proportion of men don't tolerate them. There's some common side effects that you can get, and still from all of the research done using these medications and through penile rehabilitation, the response rate is still less than 50%. The injections, of course, this is a bit more involved, this treatment, but they work very well. A majority of men get a response to having the injection. Of course, just by their nature, a lot of guys don't like using these injections. In terms of the criteria for penile rehabilitation, they work well. They flush the tissues with highly oxygenated blood, and they prevent scarring and initiate penile stretch, which can prevent scarring further. Of course, they have side effects, priapism, where they can give you an extreme erection that brings on scarring very quickly. A lot of men still don't like the lack of spontaneity from using them. And again, from all of the research in terms of pure rehabilitation, how they get you back to your pre-morbid or pre-radical prostatectomy state still remains unclear. Vacuum devices, again, are quite commonly used now, and they're cheap and very easy to use. They don't exactly satisfy the criteria for penile rehabilitation because they're not bringing in well oxygenated blood. They're just a negative pressure device that actually sucks in venous blood. So it's more of a cold, dark erection, but they do stretch the tissues and they can potentially reduce any scarring. I'll now pass on to Professor Coombs to discuss our procedure further.
So the technique that we use is a technique called Endocyte nerve grafting. And there has been a fair bit of chatter in the urological world since we introduced this operation, calling it experimental. And just so everyone knows, endocyte nerve grafting in plastic surgery has been used since 1903. So it's not really an experimental procedure, it's just a technique that has been reapplied to a new area. So that the first time it was used was in facial palsy, and then this lady, this is from the paper from Balance in the British Medical Journal in 1903, where they restored her smile mechanism by using endocyte nerve grafting. So I just want everyone to understand that this is a well-established technique that's just being used in a new way to produce outcomes that weren't available prior to this being used for this purpose. Thanks, Dave. The next slide, if you could. This procedure of endocyte nerve grafting from the femoral nerve, which is the nerve that goes to the quadriceps muscle, I'll talk a bit about that in a little while, was developed by a chap on the right-hand side here, if you're looking at it on your left, who's Fausto Viterbo, who's a Brazilian plastic surgeon. And this is him with David at the American Neurological Association meeting in 2018, where David won first prize for best paper, best poster presentation for our work on restoring erectile function using this technique. Fausto started doing this and reported, thanks Dave, next slide. Fausto reported his work in 2016 in the British Journal of Urology. And you can see there in the third point, he had 6 patients achieve full penetration following the endocyte nerve grafting the way he does it. And the other 4 patients of the 10 had semi-rigid erections at 13 months. I visited Fausto in Brazil back in 2014, or 13 actually, and looked at his technique. And when I came back to Australia, David and I have subsequently modified it, because I think there are some things that you could do that could improve the outcomes and improve the amount of nerve regeneration that you can get down the nerve grafts. It's also been utilised in rat models, so it's been tried with where they've divided the nerves that in rats that go to cause erection, and using endocyte nerve grafting resulted in a 42% improvement. So it's not an experimental procedure, it's one that's been researched and developed on well-established techniques, as I said, that have been around for 100 years. So next slide, thanks, Dave. So what we do, there's a few operative slides here. I hope no one's going to feel queasy, but there's not a lot of blood. So this is what we do is we take out the sural nerve, which is a nerve that goes from the back of the knee down to the behind the ankle. And this nerve is the commonest nerve used in nerve grafting techniques in plastic surgery, and it's used every day by plastic surgeons to treat people with facial palsy or nerve injuries or children with nerve injuries. So it's a very well established donor because it has a minimal downside by harvesting it. The downside is mainly, you can see in the schematic where there's an area of decreased sensation on the outside of the foot, which can give some burning pain or some shooting pains, a bit like you whacked your funny bone for a few weeks after the surgery, but it settles down relatively quickly. And Tony, I'm sure, will talk about that when he has a chat. And then after we take that nerve out, thanks, David, we then, if you're looking at the left-hand picture by itself, we make 4 incisions, 1 in each groin and then 1 on each side of the penis. And in the ones in the groin, we then isolate what's called the femoral nerve, which is the yellow cord going down to the leg. And that's the nerve that goes to the quadriceps muscles or the thigh muscles. And what that nerve does, it releases acetylcholine, which is that chemical that David was talking about to cause function in the muscles. So we tunnel the nerve graft from the base of the penis across to the groin and then connect it in the, as you can see in the lowest slide, the lower drawing, connected to the side of the femoral nerve, which we do using microsurgery. And this is where one of the main differences between our procedure and the procedure in Brazil is that we actually divide part of those nerves so that we can guarantee better nerve regeneration down the nerve graft. And the best way to think of a nerve graft is that the nerve graft is basically an extension cord. So it's like you've plugged it into an electrical socket at this end, you want the light to work over here. And so you need the copper, which is the nerve fibers, to grow all the way down it. So here you can see a patient who we've connected the nerve graft to, and this is just a schematic again of that. Next slide, thanks, Dave. And then we take it across to the penis, and you can see the nerve graft coming out near the penis, and then we take that nerve and then delicately place it within the corpora, which is the barrels of the penis that go hard when you get an erection. And that's schematically shown on the left-hand side there. Thanks, David. And then what happens in the bottom picture here, this bottom schematic, you can see that there's these, we prepare the nerve graft in such a way so you end up with this fine branching or nearly like a root system coming out of the nerve graft. And each of those little rootlets or nervelets carry the acetylcholine that gets released. And thanks, Dave. And as you can see, we were talking about this before, again, where inside that red oval is what we're trying to do is re-establish a population of nerves that will release acetylcholine, which is one of the primary instigators of erection. So that's a quick overview of how we go about the procedure. I hope I didn't make anyone fall off the table and your lunch is still okay. Thanks, Dave.
Thanks, Chris. So this is just the summary of the first group of our patients that we presented for publication earlier last year. And if I can draw your attention to the graft on the right there, the graft, and you can see all the dots lower down on the graph before they've got their sural nerve grafting. And then by 12 months, 71% of these dots, which represent patients, are above a threshold, which is a measure of 17 of the quality of the erectile function for these men. And we know once you can which you can rate at a level of 17 or above. That reflects good quality penetration and maintenance. And this was our first group there. We also measured their quality of life changes, and you can see on the table below there, we got a very strong response in this group of 94%. So the majority of patients got back to strong erectile function, but of the group that didn't, a vast majority of those had a significant improvement in their quality of life measures as well through this procedure. So again, as Chris said, it's quite a tolerable procedure. The regular and predictable side effect is the numb areas on the side of the feet, and they can be considered permanent, and they'll be permanent. But the majority of guys that come back to us aren't bothered by these areas, and most of them register that the areas actually shrink over time. You can also get some weakness in the quadriceps muscles, and this is where the femoral nerve supplies the quadriceps muscles, and when we're mobilizing the femoral nerve for the endocyte nerve grafting, you can get a degree of bruising, but again, this is transient, and we warn the patients not to walk downstairs too quickly to begin with, and that usually takes care of itself within a few weeks of the procedure as well. Because we've been going almost 6 years now in developing the procedure, we've got a better understanding and a better feeling for the patients that will respond positively to it. And there are a number of factors now that have come to the fore with regards to this. Of course, age, younger patients tend to heal much better, so they tend to do better. But we've had success in patients up to 70 years of age. Those patients with a strong pre-morbid, pre-radical prostatectomy sex life do better. And that infers the next point, that infers a lack of other processes that can have a negative impact on your erectile function, disease processes such as diabetes and medications such as antidepressants and beta blockers. Of course, having a supportive partner is always going to make the process more likely to have a good outcome. The recovery of the process can take 6 to 12, even longer, 6 to 12 months or even longer. So a supportive partner is very important. And most importantly, really in recent times, over the last year or two, we've come to understand that the timing of the procedures is very important. In that first group that I just presented there, the actual time between radical prostatectomy and getting to us for nerve grafting was way over 2 years, and they still did well. But recent times we've been doing patients, particularly non-nerve sparing patients, where we've been doing them soon after their radical prostatectomy, and classically these patients don't return to spontaneous function at all. But we've got a group of around 20 now that have had a response in about 62 or 63%. And we think part of this has been because they've had the procedure early on and they haven't been allowed to scar up. So the longer the time after a radical prostatectomy, the more likely that the tissues are going to change and potentially scar down. And we're potentially alleviating that. Of course, there's a controversy there, particularly with the nerve sparing group, and we've been leaving those patients until they get to 2 years post their radical prostatectomy to see if they can have some spontaneous recovery just from having their nerves spared. But we've also seen through that time, a lot of these patients are scarring down, and then the nerve grafting will never work. This is just 2 sets of data here. The patient on the left was a patient who had a very strong response to our surgery. He was actually 10 years, now that I've said that, he was actually 10 years post-radical prostatectomy, and he recovered his function at 6 months after grafting. He then got back to his baseline function and was not requiring any medications at all by about 15 months after our surgery. And you can see the lower graph there, his quality of life measure bounces straight back up to 100 as well. The other set of data here is a failure. This was a man 4 years post nerve sparing radical prostatectomy, and he actually got a good degree of erectile strength back after the procedure, but could never get any significant maintenance back. So he was happy about that. It was the first erectile activity he'd had in 4 years. But you can see there, he never gets to 17 in that top graph. He never gets anywhere near it. But in the lower graph there, measuring his quality of life, a significant change in quality of life is 10 or more. So he did have a significant improvement in his quality of life, but he never got back to strong erectile function. And we think this was because he'd been scarred down beforehand, and the scarring leads to the venous vessels remaining open. So the blood can come in with an erection, and that's what the nerve grafting does. It brings more blood in, but if you've got scarred veins, the blood's already going to drain straight out. So they can get erections, but they're never going to be maintained. We've applied the procedure now to a number of other causes of surgical erectile dysfunction. TURP is a procedure for benign changes of the prostate, and we've had 3 patients there, 2 of which have responded to the surgery. A cystectomy is where your bladder's taken out for bladder cancer, and we've had 2 patients there, one that's recovered and one we're still waiting on. Abdo-perineal resection is for bowel cancer, specifically rectal cancer, and these patients have a high risk of erectile dysfunction, and we've had 2 patients there, one who has responded to the surgery and got his erectile function back. And most interestingly, we've had a patient who has had radiotherapy post-radical prostatectomy, and he's an academic in one of the cancer centres here in Melbourne and has a very good understanding of the processes. He had a nerve-sparing radical prostatectomy and then required salvage radiotherapy after this. He had evidence that his erectile mechanism was still viable, and he was getting partial erections, and he's almost at 12 months now, and his 9-month assessment showed that he had a significant response to the surgery. So his measures were about 13 or 14, and we're waiting on further data there. We've deliberately kept away from radiotherapy patients to date because the fields of radiotherapy not only hit the nerves, but they hit the corporal bodies and the erectile mechanisms themselves and cause significant scarring. So we've had some advice from the radiation oncologists about potentially being able to image and have a look at the blood vessels better. And we'll come back to this, but it's exciting, and we'll wait and see how this first patient goes and take it from there. So where are we heading from here? We're looking to get to 100 patients and potentially publish them, and probably still another year or 2 away from that. In the meantime, we've got a number of papers that will hopefully get out in the new year. We've got a group of patients that are actually 10 years post-radical prostatectomy and then have responded to our surgery, and they're easier to see now, and they present in a particular way, and they can demonstrate a viability to their corporal bodies or their erectile mechanism, and we enhance that. And also a group now of 20 non-nerve sparing patients that I alluded to before, and we're looking at a success rate of just over 60%, and this is quite exciting, as well as the traditional group of non-nerve sparing radical prostatectomies have a very small chance of ever recovering any sort of spontaneous function. So we're hoping to share this with overseas units as well, and we had the beginnings of a relationship with a number of units in the US before coronavirus. We've been approached by Harvard and also another group in New York. It's all a little bit on hold, but hopefully we'll get back to meeting up with those guys and developing the surgery further. So just to finish with on this slide, this is a new model we are proposing now for penile rehabilitation. And when you really get down to it, penile rehabilitation is maximising the health of these tissues, particularly the penile blood vessels, while you're waiting for the nerves to repair. And what we're looking at now is progressing penile rehabilitation, of course, with the tablets, injections and vacuum devices in terms of blood vessels. But what we'd like to do now is rehabilitate the nerves as well. And this, I think, makes good sense because the majority of the issue in erectile dysfunction for men post-radical prostatectomy is around their nerves. So if we can focus in on now and rehabilitate their nerves with our surgery, I think we're going to get much better results for this large group of guys that suffer erectile dysfunction after radical prostatectomy. I think I might pass on to Tony now, if we could. Tony French, and thank him for his time and being involved today. Tony, if I can pass on to you, just to give us a summary of what you've been through with your radical prostatectomy and sural nerve grafting. Thank you.
Thanks, David, and also like to thank Professor Coombs for the opportunity to speak to everyone today. Just to give you a bit of a timeline of what happened with me was I had a radical prostatectomy back in 2014 when I was 49 years old. So I was considered pretty young to be having my prostate taken out. And that was a nerve sparing radical prostatectomy, and they were able to get the cancer early, and so I was able to have erections after that operation, but they weren't really strong enough to have intercourse. So, and I was even using Viagra at that time, and it just wasn't enough to have the ability to have intercourse. It was just not strong enough. And I heard Professor Coombs on ABC Radio back in the beginning of 2019. I was just driving into work, and he was talking about this this sural nerve surgery that he was doing on patients who had had their prostates removed, and this was the first time I'd ever heard of it. It was a real light bulb moment for me. I was driving into work, and I'm saying I got to ring this guy on Monday because I've been looking for something like this, and because it was 2019, it was that 5-year period which Christopher talked about earlier, being and David as well, being really important to get that surgery done. So I was only a couple of months shy of 5 years down the track. So I made a decision fairly quickly after chatting to the guys, and decided to have the operation in July of 2019. And I'm happy to say that apart from the usual side effects that you get from having your nerves removed from your legs, like the numb feet and the shooting pain up your leg if you're walking downstairs, it can really throw you, because it can throw you down the stairs at times if you're not ready for it. But I'm a runner, and it hasn't affected my gait at all. Like, those things just really diminished after time, and I've still got the numbness in my feet, but like I said, I'm a runner and it doesn't affect my gait, and I can still run half marathons and stuff like that without any effect. So but the main thing that happened with me was 9 months later, I was having erections strong enough to have intercourse, and that was a real breakthrough for me. Like, 6 months, you've really got to spend letting the tissues and nerves grow and recover. But after 9 months, I'd moved from Viagra to Cialis, only because Viagra sort of heats you up a little bit, and it had some of those effects that was on the slide before, you know, headaches, red face, all that type of stuff, whereas Cialis is a little bit more gentler in that way, but still getting the same result. 18 months down the track since having the operation, you know, I'm having regular intercourse. My life has improved out of this world, you know, like it's just, I'm just so happy I got it done. There really wasn't any downside to it. And it's just like being able to talk to you today from somebody who's experienced it firsthand. It's just a no-brainer for me. Like at the time, I was just, it was a big decision to make, but I made it instantly only because I believe in what these guys are doing, and my life has improved as a result. So I'd like to leave it there for today, and thanks for letting me share to you all today. So see you later.
Well, that from Tony was something that was very, very interesting, and you know, it's so good to hear, you know, from a patient. I mean, with David and Chris and the presentation that you've given there is fantastic, and all the medical side of it and the medical advancement, and from someone like myself who was a patient, and Tony, I had a similar story, but many years ago. So this operation wouldn't be for me, but I had radical prostatectomy and nerve-sparing operation when I was 48. So it's of great interest to me, but I know that everyone that's watching this webinar today will find it fascinating to actually hear a success story from someone like yourself. So thank you, Tony, very much for your openness and letting people know how successful this has been. Now, there are, down the bottom of the screen there's a Q&A section there. So if anyone has questions, if you can put those in there. I do notice, I think in one of the, in the chat section, there is a question from Peter Ham, basically saying how much does the operation cost, or is there a cost to it? So maybe David or would like to answer.
I'm happy to talk about that, Jim. This is as I said, it's got it's a well-established technique. So there are rebates for the surgery. It's very difficult to give an absolute cost for any operation because it depends on what sort of rebates you get from the individual insurance companies. So it's certainly before anyone has the surgery, we do give, David and I give formalised quotes which are individualised, so that we know that what the rebates are that you're going to get from your health funds. There is an out-of-pocket cost with the surgery, but we do let everyone know beforehand. So it's a very difficult thing to actually give a ballpark figure because it is so variable depending on the health insurance that the patient has. I think you're muted, Jim.
There we go. Thank you. The Zoom challenges we have. Thank you for that, Chris. And we haven't got any other questions that have come in at the moment. I did have one earlier, which we might like to answer. It was by a gentleman who emailed me, and obviously having some issues with incontinence and lack of feeling down there as far as incontinence issues were concerned. And he wondered whether this operation, by increasing the feeling in the penile area, whether that would help with his incontinence or understanding of that.
Yeah, the short answer there, Jim, is no, not at all. It's a completely different mechanism, and we don't go anywhere near the continence mechanism or the nerves and muscles that supply the continence mechanism. So no, we can't say that this is going to have any impact on that. It's purely for erectile function.
Very good. Thank you. Thanks, David. Look, we're starting to get a few questions in, which is terrific, actually. We've got one here. Assuming the surgery is successful, but the patient still experiences leakage during intercourse, is that going to act as a deterrent for any of your patients?
That follows on, I think, Jim, a little bit from the previous question there. No, we couldn't. I think that the patient there is talking about climacturia, which is a known phenomenon post radical prostatectomy. Again, we can't say that we're going to have any impact on that because it's a muscular mechanism and more of a continence mechanism. So, whereas we can get the erections back and get you functional again there, we won't have any impact on the continence mechanism at all, and you could potentially have persistent climacturia after our procedure.
Right. Thanks very much, David. Another question is where is the procedure? Which hospitals is the procedure performed at?
Cabrini Brighton or Lineker Private Hospital, the two private hospitals in the Bayside area in Melbourne.
Okay. And I think you mentioned this in the presentation, but is there a maximum time after the operation before this surgery is not effective? And I think I recall you saying, Tony, that it needed to be within a 5-year window, I think.
Ideally, Jim, and again, it depends on what sort of radical prostatectomy you've had in terms of whether it's non-nerve sparing or nerve sparing. If it's a non-nerve sparing, it's ideal to have it as soon as possible. It is. There are particular ways in which patients present, and we've had success in guys up to 10 years after the radical prostatectomy as well. But that's particular characteristics of their erection or their residual erections that we look at there as well. So I'm happy to assess everybody, and there are particular things we look at. Of course, if you'd not had an erection or any erectile activity for a long period of time, you're always going to struggle, but there are other factors that we take into account.
Yeah, very good, David. I'm 18 years down the track, so I don't think I'll bother you.
Okay. Well, we can talk, Jim. You can always be assessed, but
yeah, thank you. But no, it's true. I mean, it doesn't really matter, how long it is since you've had the surgery. I mean, there are people who it's worth asking the questions and seeing what can happen, because the fascinating thing I found is the lift in the quality of life for so many men that have been through the procedure, and I think that's just so important.
Yes.
Yeah, I think that's really something that we need to highlight. Our study was the first study that's ever looked at that, and to show that the results were sort of predictable in those who regained their erectile function, but the really interesting thing was how people felt who didn't regain their ability to have intercourse. Most people get a response. We've only had one patient, David, that hasn't had anything, I think, maybe 2.
Yeah, 2 out of 90. Yes.
Yeah. So it's everyone gets something, and nearly everyone gets something, and that ability to get something then makes it a little easier potentially for other sexual activity like oral sex or manipulation, that sort of thing. So it's not just an all or none phenomenon in a way. Yes, everyone would love to be having intercourse, but even the ones who don't get that level of erection still feel better about themselves. And I think it's because of that.
I had a couple of questions come through about, how can someone get an assessment, or how can they contact you or the hospital if they are interested in talking further about this?
Yeah, I was just looking at, there's a question here from Mark. 62-year-old had a non-nerve sparing salvage radiotherapy, still getting erections with Trimix. Certainly that's the sort of things that we're looking at. And along with that, David is assessing vascular function or the blood vessel flow in the penis with Dopplers. And so certainly, Mark, it would be, certainly we'd be happy to assess you, and certainly make a contact with David's office if you wish to, and he can do that and have a chat to you about it.
Thank you for that. I think that's probably the best way with some of the more technical or personal questions that we get, that someone could contact you direct on that. Going back to the costs and the procedures that are obviously done in the private hospitals at the moment, is there any sort of discussion or talk about the procedure being made more available to more of the population in the future? It's with more government support or whatever?
Yeah, well, certainly. David and I don't work at any adult public hospitals, and so therefore we can't treat adults in the public system. In saying that, we've had chats with some of the public hospitals in Melbourne, but at the moment it's a procedure that's in the private system at the moment. But certainly, if it became more mainstream, part of that's due to a lot of the urologists really just haven't referred patients because they've have this belief that this is an experimental procedure, which is not an experimental procedure at all, as I alluded to in the talk. And so I think that, once they get think about it more and understand the procedure and the nuances of it, then that may make it more available as well.
Yeah, that's very good. Where are we there? We've got another question from Ian here. It says he's 75 and had the operation in April. It says he's getting erections, but he wants to know if his age is an issue or whether he would be a candidate.
When we talk about thresholds for age there, Jim, and 70 is a generalised threshold because it's in microsurgical terms, it's a differentiator between good healing and bad healing. Physiologically, there's always a lot of variability as well. So, around here in Melbourne, we have 75-year-olds who ride their bike around the bay every weekend and they're very fit. So we take each patient on his individual merits, and I think he'd need an assessment, of course, like everybody else, and we have a look at his penile vasculature and put his entire story together there. But it sounds like he has a viable mechanism, so it'd definitely be worth an assessment.
That's very good. Yeah, I think what have we got? Another one. Basically, what does an assessment involve? Is it a physical examination, or how detailed is it if someone goes in to have a chat to you?
Yes, certainly. So they need to be assessed urologically and microsurgically, and from a urological point of view, they need to have a Doppler penile ultrasound, and that's our mandatory investigation now, and it's looking at the vasculature, looking at the blood vessels. We're all about putting nerves in and regenerating nerves, but if you haven't got the right blood vessels, or if there's been significant scarring in the blood vessels, the procedure won't be for you. So part of the workup now is a Doppler penile ultrasound, which looks at the cavernosal arteries and veins to see if they're viable.
Very good. And as someone from myself being from Sydney, there's a question come up here. Is the operation only performed in Melbourne, or is it available in other states?
Currently, we're only in Melbourne. We're only in Melbourne, but we're looking at the east coast of Australia as well. So potentially, again, it's been a bit of a funny year, so all of this has been on the back burner, but potentially starting up a service in Sydney very soon.
Oh, that's good to hear. Another question that's coming is Peyronie's an issue when considering this operation?
Peyronie's disease is a well-known side effect of radical prostatectomy, or is now an accepted side effect of radical prostatectomy, and it reflects a different type of scarring to the one I'm assessing you for this procedure. So it potentially can have an impact on the outcomes with our procedure. So you'd need to be assessed in terms of that very closely. Doesn't directly rule it out, but you'd need to be assessed closely.
Very good. Okay, I think we're pretty well gone through most of the questions at the moment that have come in, which has actually been good because it's been a wide-ranging number of questions that have come in. And I think hopefully that's helped answer some of the questions that others might have had whilst watching this presentation.
There's just another one that's popped up from Eric. Can the Doppler ultrasound be done in Sydney? And that can be done, can't it, David?
Yes, it certainly can. I prefer to do it myself, to assess you properly myself, but of course, considering everything there, yeah, Doppler penile ultrasound is readily available everywhere, really, with your good local radiologist. So that's what we've been doing up to date. We've treated men from all states of Australia to date, and they've had Doppler peniles on their assessment. And this year we've just been doing it all by Zoom as well for the interstate patients. So they come with their Doppler penile ultrasound results.
Yes, it's certainly been a challenging year this year to try and do anything interstate, but hopefully next year things will be back to some sort of normality, whatever it is. But the other thing I should point out is that this presentation has been recorded and it will be on our online channel on the PCFA website on the online community, and that's so it will be available for people to watch who might have missed the presentation or may not have watched all of it, and also particularly for the support groups. I know many of the people watching today from our prostate cancer support groups, and so it'll be able to be viewed by the support groups as well. So I'm sure it will get quite a number of views in the future as well. There's nothing else come through there, so maybe Dave and Chris or Tony, if either of or all of you want to have just a sum up or anything, if there's anything else you want to say, and then we can wrap it all up.
There's just one question more I could see there, Jim, that might be appropriate. Peter has asked whether you can have the nerve sparing incorporated with a prosthetic pump. And we haven't discussed anything about prosthetics today because it's not really a form of penile rehabilitation. But if you are a patient that hasn't had the response that you were hoping for with our surgery, you can still go on and get a penile prosthesis without any troubles at all. But that's a completely different process and it involves a pump. Whereas what we're trying to do is just make the most of your residual function that's there through your natural tissue. So they don't go hand in hand with each other and they don't work with each other at all. But if you don't get the result with our surgery, there's nothing in the way of going on to a penile prosthesis at all.
And it's probably important to add, David, that if you've had a penile prosthesis, this procedure, the nerve grafting procedure, is not suitable for you, because when they put in the prostheses, they actually remove the tissue in the corpora that we are trying to get the nerves into.
All right. Well, with that, I think first I'd like to thank Chris McNamara from PCFA as well, who's set up all the video links and the webinar links today and done all the emails for us and made this work behind the scenes. So again, thank you very much, Chris, for that. But particularly want to thank Professor Coombs and Dr. Dangerfield for your time today, because I know both of you are very busy men, certainly in demand, and I can understand why. And so to give up your time today for this webinar, greatly appreciated. And also, Tony, thank you so much for, as I said before, giving a patient's perspective on this procedure, because a lot of men out there would be very pleased to hear what you had to say from a patient's point of view. So again, thank you to each and every one of you. And as I said, this webinar will be available online for people to watch.